Good morning. I will call the Cook County Public Health and Human Services Board to order. Do we have any changes or additions to the agenda?
Yes, we'd like to introduce Allison Plummer, our new Financial Assistant Supervisor, if possible before the program update, as she has to get to a 9 o'clock meeting.
Okay,
Thank you.
And approval of the consent agenda?
So moved.
A second.
All in favor?
Aye.
Aye.
Thank you. Okay.
So we'll welcome Allison Plummer, who is our new Financial Assistant Supervisor. That was approved at the last regular board meeting. And I know most of you already know Allison from her presentations to this board, but wanted to just recognize her today and thank her for moving into this position. Allison has to get to a phone meeting at 9, so I don't know, Allison, if you want to say anything or hello or a little bit about yourself.
I just wanted to say thank you for the opportunity to progress in my current position, expand on my current experience, and I really look forward to continuing the great work that Allison has really laid out a foundation to with our team.
Very good. Thank you
Welcome.
and welcome again. So we will move into our program, which is going to be presented by Greg Bernier on Wilderness Outpatient Treatment Programming Update.
Thank you. I'm just going to pass something out for you first. I told this story before, but when I worked for Harry Swift, he said, never do this.
What's this?
It's not information.
But before.
Because nobody will listen to you,
Because
they'll read
everybody
it.
will be reading it and not listening, but I know it isn't the way this works.
No, we need it.
We can do both.
Yes.
And you've got, okay. So I'm like to talk about three things, just the program as it is right now here in Cook County. I would like to talk about something called substance use disorder reform that was passed by the state legislature this year. And then talk a little bit about our substance use recovery court. So the first item, boy, this isn't the way I rehearsed it at all.
Do you want to do
The
it
first
that way?
item on my agenda. If you look at the first page, things have been pretty steady throughout Cook County over the years. We had a little bump in the Rule 25 assessments around 2012, 2013. We were doing quite a few, and then Grand Portage started doing those assessments themselves, and so we were doing fewer, and that's remained about the same. It looks like we're due to increase the number of assessments this year a little bit, but not by much. Clients in outpatient have increased a bit. We're getting more referrals from inpatient for outpatient clients who weren't seen by me in the beginning of their process. I have somebody starting this week that I've never seen. I have no idea who this person is. But somebody else did an assessment. She went to inpatient treatment, and now they referred her back to outpatient for continued care. Our group right now is pretty large. We used to have a maximum group size of 8 just because that was ideal for me. But this year, rather than put people on a waiting list, I've just brought them into the group. And I find that I actually like that better. A bigger group is easier for me. It's better for the clients. We used to have our aftercare program separate from the primary outpatient group. They would meet on Tuesdays from 6 until 7:30, while the primary group met from 6 until 8. They met in a separate room. These are people who graduated from outpatient and were getting some continuing care. The aftercare program is not charged, it's free. Once a person is discharged from outpatient, the billing stops. I no longer keep notes, not required to do anything at all But Harry Swift and Mary Jane recognized that people's chances to remain sober for a longer period of time improved if we kept doing something with them regularly. And so we just provide this as a free service. And what I've done this year is, rather than have that group meet separately in a different room, it was kind of distracting because we could hear that group in their room and they're laughing all the time. And in my group, we're dealing with the beginning of recovery. And so now that aftercare group meets with us on Tuesdays for an hour, for the first hour. And I found it really helps both groups. The people who are just starting treatment who have all these problems and can't imagine how they're ever going to solve these problems or really change are sitting with people who have done the very same thing. And then for the aftercare group, I think part of their recovery is helping other people, and they're there to just provide inspiration and hope. And I find that they show off a little bit, and they talk about they talk a lot about how their lives have changed, and it's good for the primary group to hear that. So that's the way I'm doing it now. And I like it, and the clients, the aftercare people like it. The primary care people, because they're just starting in recovery, they're a little disturbed by such a big group. But over time, they get to know these people and they begin to open up. I've been lucky this year and last year that I've had groups that have really supported each other. And I think it's just a fluke of who's in treatment. I'm not doing anything different, but they are. And, it isn't always like that. Sometimes it can be very difficult for everybody, but it hasn't been that way this year. So any questions about the group? So there are 10 people in the primary group, 5 men, 5 women, 7 people in the aftercare group right now. Oh, okay, good. Substance use disorder reform. These are big changes in the way treatment's going to be provided to people with a substance use disorder. We've always known and tried to implement a model of care that recognized that a substance use disorder is a chronic condition. But the way treatment has been done in Minnesota, it's more of an acute care model. And that's because people will go to inpatient treatment, that's acute care. Then they get referred to outpatient, that's acute care, I guess. And then they enter our aftercare group, and they're no longer getting any services unless they volunteer for them. Some statistics that are kind of shocking. When I went to treatment 14 years ago, we were told at some point, and the counselors loved to do this to us, is they would tell us ask us to look around the group, and they'd say 9 out of 10 of you are going to relapse within 90 days. And then we'd all look at each other and we'd think, you poor sucker.
Oh, yeah.
Because
It's going to be me.
I'm going to be the one. I'm going to be that number one. Well, and because most of us did feel that way. But I relapsed after, I don't know how many days it was. I was thinking about that this morning. I really wanted to be sober. I wanted it. After, let's say, 90 days, I started to drink non-alcoholic beer, which of course has a little bit of alcohol, and I knew that. That's why I was drinking it.
Lots of it.
You couldn't drink them fast enough, but I sure tried. And then I moved, and I still thought I'm sober. And then I went to 3-2 beer. And you can't drink those fast enough. And so then I went to light beer. And you can see I progressed until I was drinking my favorite Heinekens again. And I was in a full relapse. And so the question is, what happens to a person who really wants recovery, wants sobriety. Why do 50 to 70% of the people relapse after 90 days? 50% of all people in treatment have been there before, maybe 3 or 4 times. What's happening? But one thing we know, this is statistic, but it seems pretty reliable. If you are sober for 5 years, your chance of being sober for the rest of your life appear to be about 95%. So we didn't have anything in place to continue to support these people after they get out of outpatient. And so we asked the question, what is wrong? I did this recently in the group, gave these statistics, said, what do you think is wrong? Why is this happening? And it's really a simple thing, that people just stop following their recovery plan. It kind of peters out. They struggle to maintain the changes they made when they were in inpatient and outpatient. When, like myself, just gung-ho about this, and just couldn't do it. And then the third point, which is really, I think, important at the heart of it, is people, myself included, I did what I wanted. I waited for the feeling that I wanted to do these things before I did them. And that's a problem, because if we wait until we want to do something really uncomfortable, we might not do it. So that's the problem. So substance, you're looking...
I'm puzzled by that.
Why?
Yeah. That you could do it if you didn't want to. That's the part that I'm puzzled by.
Yeah, well, I did this once here. I don't know if I've done it with you, but just cross your arms. Did I do that with you before?
I've seen it in other...
Oh, okay.
Yeah.
Now cross them the opposite way. And how does that feel? And you got to think about it, right?
Yeah.
This is a simple change, but we're creatures of habit. And so it's just difficult for people to make changes. And but they make these changes when they're in treatment, but they don't continue to maintain those. And so what the substance use disorder reform wants to do is to continue providing services to these people beyond the time they're in outpatient for a longer period of time. To provide them with people who will take them to meetings, take them to appointments, to help them make those appointments, to kind of accompany them as they're going into these kind of uncomfortable places. That's one of the changes. So, 4 things are changing. Something called direct access, care coordination is being added, peer recovery support is being added, and withdrawal management is being added. What direct access is right now, if a person doesn't have insurance, their treatment is paid for by the county, who gets their money from the state in consolidated treatment funding. But in order to qualify for consolidated treatment, a person has to have a Rule 25 done in their county. So they come to see me, I do an interview, I've got 10 days to complete the evaluation. In the meantime, and I say, yes, they need treatment, they don't have any money, they have to get approved for consolidated funding, and then they can go to treatment. The change they want to make is that instead of a person having to go through this at least 10-day process, they can go right to the treatment program and say, I want to do treatment. And even if they're from another county, the treatment program will do a comprehensive assessment and then contact the county for funding. So they don't have to wait. I had a really kind of startling example of this about a year ago. I got a call from a person who said his brother is just drinking himself to death and he wants to do something. He wants to help his brother. What can he do? And I said, well, the first thing we have to do is he has to come in and see me and do an assessment. Didn't hear from them for a few weeks. And then I got a call from the brother, and there was a day when his brother wanted this to end. He wanted to go to treatment. So the brother took him to CADT in Duluth. They had an opening for him, but he couldn't start treatment because he had to come back up here to get a Rule 25, 10-day process, and then he could go to treatment. And it didn't make any sense to me or to anybody else. Why do you have to jump through this hoop? Because we know that a person's motivation to change is kind of fleeting, but they will have that morning, that day when, yes, today I want to do it. And if we can't act quickly, the next day rolls around and then they start thinking, well, maybe not, And so they're trying to address that. The Rule 25 is an 18-page document. What they're going to change to is something called a comprehensive assessment. That's a 7-page document. It still has all the relevant information, but once this reform goes into effect, people will no longer need to have the Rule 25. They can just go to a treatment program like myself or ourselves or CDT or any other program in the state, no matter where they live, and get the assessment and get into treatment as fast as possible. I don't know how this is going to impact waiting lists that all the treatment programs have, because we call treatment programs now after we go through our 10-day process, and they have to wait 3 weeks to get in anyway, but this is definitely an improvement. So that is one thing that's changing. 3 things are being added. One thing that's being added is care coordination. As the Department of Human Services envisions this, myself or a case aide can be trained to provide care coordination for clients. And what this means is this will help clients, because right now they'll come to see me and I'll do an assessment and I'll say, well, you need to go see your doctor. You haven't seen a doctor for a couple of years. I'd like you to get a mental health assessment, so just call HDC. You're not working, so we'll have to find somebody who will help you find a job or maybe get trained. You don't have a place to live. A lot of people don't have a place to live. They've burned out their families. Maybe they lost their jobs, so they lose their apartment. Now they're drifting from bed to bed. They aren't really sure where they're going to sleep next week. Families start getting tired of this, and so they're effectively homeless. And so people need help just ironing out that detail. And when I tell people these are the things you got to do, I realize they don't know how to do them. I don't know if you've ever been in therapy, what was that day like when you finally made that call to make an appointment to see a therapist? That can be delayed for weeks just out of fear, and because you wait until you want to do it, and maybe you don't want to do it. So a care coordinator could help a person do that. Wouldn't do that alone. I know how to call. If I'm the care coordinator, I know how to set up these appointments. We're going to set up the appointment. I make the phone call. They're busy, so let's go right over to HDC and just see them and make an appointment. It will help our clients if there is somebody who's being paid to do that. So that's one change. Another one called peer recovery support is another paid position. We're going to be able to bill for this. This is different than a sponsor. Although it may not be different than a sponsor up here, but I think in the rest of the state it is. A sponsor's job is to help a person go through the 12 steps and remain sober. And it's a person in recovery who sees us differently than our family does. Just to tell you a story about myself, this is all confidential, right?
It's being videotaped.
It's not confidential.
You're on TV.
Well, fine.
Clearly, it's not.
About 2 years ago, I got kind of pretty depressed around this time of year. My cat got sick. My son gave me a kitten for Christmas. He got sick. I had to travel to Duluth 3 times in 3 days to get this cat help. And as I was making these trips back and forth, I was wondering, who's going to do this for me if I get sick? And I started to feel sorry for myself, because I asked, well, what am I doing living up here? away from my family. I like my life. I like everything up here, but I'm so far away. I started feeling kind of depressed about that. I began to isolate, but I had a sponsor. And I told my sponsor what was going on. The sponsor sees me differently. My family's saying, oh, we love you. We'll FaceTime on Christmas and Thanksgiving. We'll call you every day. And that's what families do for you. My sponsor looked at me and he said, you can't isolate. I was staying at home. He said, you need to get out and do things. You can't do less, you have to do more. Because he was seeing me as a person in recovery, and he was seeing that this could be the first step to a relapse. That's what a sponsor does. They see us differently. And so he gave me a list of 4 things to do. I didn't want to do any of them. I couldn't imagine how they could make any difference at all, because they took me out of my house. But I did them, and he was right. It's just somebody who could see me differently. So that's a sponsor. A peer support person is somebody who's also in recovery for at least a year, but is that person who will take me or a client to an AA meeting, who will introduce them to people in AA and help them get a sponsor. Somebody who is like a companion on a person's road to recovery. And it really increases the chances that a person will do the things and continue to maintain these changes that they learn to make when they're in treatment. So that's a paid position. Care coordinator and peer recovery support person. The county will be able to bill in 15-minute increments for this. The care coordinator could be me, or it could be a case aide who gets some training and then is allowed to do that. The peer support person has to be trained by a certified agency. In Minnesota, in 2015, Lori Homerding and I went to Minnesota Recovery Connection for a week for peer support training, recovery coach training. Sue Footer paid for us to do that, and it was fabulous. It was a whole week. And at the end of it, we were certified peer support people. However, we couldn't do that in Cook County because this Minnesota Recovery Connection's geographic area stopped at Duluth. So if we lived in Duluth or in the cities, we would be connected with people who were in treatment or were beginning to their recovery journey, and then we'd be supervised by Minnesota Recovery Connection, and everything would be great. But we don't have that up here in much of northern Minnesota. It just isn't there. In 2015, Recovery Connection went to the legislature and asked for funding to expand statewide, but the legislature said no because they didn't want a monopoly. Yeah, they wanted other groups to do this. At least that's what I was told. So this will be kind of a hole in our program right now. And what we've been told to do is just note in our notes and treatment plan that these services aren't available here. One thing that's different up here is what I've noticed with sponsors is they act like a peer support person. There's a person in aftercare right now whose sponsor takes him to medical appointments, takes him to Duluth, really provides this kind of service to his sponsee. And I've seen that happen a lot. But I think in greater Minnesota, Department of Human Services experience with sponsors is that they don't do that. But we're different up here. I think there's room to not bill for this service, but to see that it happens. We'll see. And I expect over time, maybe a short period of time, our geographic area will be covered by a group like Minnesota Recovery Connection, because it's just such a glaring omission. Yeah. And it's so important to this reform. So how can we not do it? The last thing is called Withdrawal Management, and that's really not going to affect us at all. This is what we call detox. People, if a person is really drunk and they're taken to the hospital here, and it's clear they need detox. Doctor says you need to go to detox. If the person refuses, the police will take him. If the person agrees, then a family member has to take them, or some friend has to bring them to Duluth. And what detox is, the way it is right now, it's there just to save a person's life from withdrawal from alcohol. If I drank for 3 days and stopped last night, today isn't the critical day, the dangerous day. The dangerous day is, see, this is Tuesday, is Wednesday isn't the critical day. Thursday and Friday are the critical days when people have died from withdrawal and alcohol. It's usually it was the second and third day. And so what happens in detox is they try to keep a person for 3 days, but then once that is finished, they're gone. They walk them out the door. And I've had many examples of people from Cook County who have been brought to detox. They're walked out the door. They have the clothes on their backs. They don't have any way to get back up here. They're on their own. And we are just, we're shocked. How this person clearly needs treatment. Why hasn't something been done? Well, the way detox is set up now, that just isn't their function. They don't have a way to do it. So the reform is going to change that when a person gets brought to detox now, withdrawal management, they're going to get an assessment, and right away those people are going to start connecting and thinking ahead to what treatment program they can go to, what sort of care they need, what other services they need. So that's a big change, and it should really, it's obviously going to make a big difference. Now the timeline for this is, for the first 3 changes, what's called direct access using the comprehensive assessments, the Rule 25, and being able to go right to a treatment program first thing and try to get in. Care coordination and peer recovery support. They would like to begin implementing that this coming July. But, and I had to write this down, I did, they need approval from the Centers for Medicare and Medicaid, federal agency, in order to implement these changes. And as the law is written, they'll begin implementing these changes in July 2018, or when they get approval from CMS, whichever comes later. They're really hopeful they'll get that approval. If they do get the approval, they're going to give us 2 years to implement and make these changes. We can make them as fast as we want, or we can take time. Now, bigger organizations are going to maybe need more time. I can't wait to do it. We're going to do this as soon as we can. The withdrawal management, the timeline for that is July 2019. Do you have any questions about this?
Okay, let's open it up for questions, comments. Jerry?
Craig, a great presentation.
Thank you.
That you're here. What happens now then if somebody is sent to detox and then they're just put out on the street? Do we have anything going on to go help them at that point, or can we send anybody, or is it still really a big hole in the service?
It's a big hole for some people. Usually if a family or friend brings them down, they know they're going to have to pick them up. But we have had people who have just been out on the street. And part of the problem is the person doesn't have to stay there. They can leave anytime they want. And a lot of the people leave on that second day because these aren't really pleasant places. All the denial that an addict has just is on display in a detox. You look around at these people and they're not like me. I don't have this problem, and I can't wait to get out of here, and they're free to go, so often they do leave. And we've had calls, how are we going to get this person back home? And so you have to find somebody to take, is willing to go down and pick them up. But it's left to our imagination and resources to solve this problem. In the new reform, we won't have that problem. So these are really great changes. And they're rolling them out fast. I was getting memos about SUD reform, and I'd look at it and I'd put it down. And then I was talking to Faith Clark. I don't know if you know her. She's Agate Bay Professionals Counselor, runs the outpatient program there in Two Harbors. We went to, she called, I was talking to her on the phone, and she asked me about SUD reform, and I said, yeah, I've heard about it. And she said, she was just all up in arms. Really, what do you think? What do you think about it? How are we going to do this? And then I started thinking, maybe I missed a memo, because I haven't been worked up about this. And I went through the memos, and I realized, well, I don't really understand how they're going to do this either, or what these changes mean to us. They would say comprehensive assessment, no explanation of what that was. Peer recovery support, no explanation of, they just say it has to be certified. Well, certified by who? A lot of questions. And so in the summer, I went to Duluth, and people in my position, I guess, from northern Minnesota were there. And DHS people were giving this presentation. And as they try to explain these reforms, I just have question after question going through my head. And I'm feeling stupid, you know, because I'm thinking everybody else must understand this, but I don't. What have I missed? And then Faith raised her hand, and she asked all the questions that were on my hand, and you could just see the room relax.
Finally.
People didn't know what these changes meant for them either. They're just DHS, and I believe they're right. They're just trying to move as fast as they can with this. When the comprehensive assessment, for instance. At that meeting, we were told we were going to use a comprehensive assessment. It looks just like the one you use now for treatment. You know, people come to me and they've have a Rule 25, but when they get into treatment, I have to do this comprehensive assessment. That's the document the state wants. They don't care about the Rule 25. So I thought, great, I got one of those.
I can do that.
That problem is solved. And then I went to another, every 2 weeks we can go on the web and we get a presentation by DHS on SUD reform, and then there's questions and answers. And there they said they're going to change it. So it's no longer going to be the thing that we're using. And so, but they said they need to work on it and they'll roll it out and they'll give it to us when it's ready. And then I went to a March conference. March is my professional organization at the end of October. And then they told us that it is going to be the original comprehensive assessment, but we're just going to add a few things. So they're working on this as they're pushing it through. And I guess that's a good model for us. And it's for clients. You don't have to know how you're going to do everything before you start doing it.
Okay.
But it's hard for us, and you know, and it's going to be bigger changes for bigger organizations. But they'll tell us what the comprehensive assessment is, and we'll use it. So.
Yes, Carla?
I just wondered if with time, and this is more extensive as I see it, you had Lori with you before.
Mm-hmm.
Excuse me. Would there be a need to have someone part-time with you, or is there a need to build a cadre of volunteers from the recovery community to help?
Yeah, I see volunteers
Okay.
from the recovery community. I don't know how it's going to look. I mean, right now, I'm talking about peer
Right.
support. The care coordination, that can be a case aide here who gets the training and then they can do that job. And the peer support person, though, what DHS is telling us is we can't do that. We can't cobble together something. I can't cobble together something on my own and call it peer support, even if we don't pay for it or charge for it, because that will be against the law. But I think if sponsors understand what, I don't know what to do really, because now we're asking sponsors to be peer support people. I don't know the answer to that.
Right.
Now, I'm hoping that they'll just see the gap and maybe extend Minnesota Recovery Connection to the whole state and then allow us to do it. They have to address it somehow.
Right.
Yeah. This reform will probably be less work for me. Maybe, I don't know. What's going to happen is probation is still going to send people to me for an assessment. Social services still send people to me for an assessment. It'll perform the same function as the Rule 25. We'd have the comprehensive assessment, then the next document is a shorter one called the summary. That's where you will still use the 6 dimensions that we use in treatment and Rule 25, intoxication, medical condition, mental health, willingness to change, continued use potential, and recovery environment. And so we'll assess those things here, and if they're appropriate for outpatient, recommend outpatient. Appropriate for inpatient, recommend inpatient. One of the changes, though, is self-efficacy, that the client is going to choose the program they want to go to. It's because we know the more a person is involved in the decisions that are being made about themselves, the more likely it is that they'll follow through. So.
Jerry?
In your outline that you gave us ahead of time, you said that alcohol and methamphetamine are the major drugs of choice in the outpatient population. So I'm wondering, well, what about opioids? Are you seeing much in the way of opioid addiction and part of your program and so on?
They lie about that. I mean, but in the beginning. But then as they're in treatment, yeah, I've used opioids. There's one person in treatment right now whose drug of choice is opioids. That person got in trouble for meth. I guess just looking at the clients I've seen this year, I know there's an opioid crisis. What we continue to deal with is alcohol and meth up here. But, part of that is because I think that several years ago, Harry Swift started these quarterly meetings with the doctors. Harry Swift and Steve Borwood did this because they were seeing opioid use just running rampant, and they knew that there were a lot of prescriptions for opiates that were being traded and abused. And the doctors, when they became aware of this, they really monitor closely their prescriptions for narcotics now. So maybe that had an effect.
So you think that maybe that the opioid crisis, so to speak, has been ameliorated to some extent by this?
No, I'm aware of 2 people who overdosed on opioids, went to the ER more than a year ago, and I never got a referral for them. I knew who these people were. I heard they were in the ER. I heard they overdosed, and I never got a referral to see them. But that happens in the ER. If they'd seen a doctor at the clinic, I'd have gotten a referral probably. So I'm just not sure. I assume it is happening. One thing I've seen either clients admitting to or there really is an increase in is injecting. It would, if I look back at some of these 2011, 2012, boy, you just never heard about somebody injecting. Now people are injecting, and that's really becoming more common.
So do you think we should be doing something different or more in Cook County to deal with this opioid crisis?
Identify people and get them in for an assessment. Now, when I was at the March training, I got trained to use naltrexone. So I carry a little, I wish I'd have brought it with me. It's a little bag. It's got 3 IV needles, 3 doses of this stuff, trained how to use it. If I ever run into somebody overdosing, I can give them 3 doses of this thing. I think we need more people like that. I can connect you with an organization that will train you to do this. You will get that training, you'll get this bag, you'll carry it with you. But
do our law enforcement personnel have that?
Has it. too. Drug companies have a big impact on this, though. The little vials I have of that drug cost about, I think they told us $200 a piece. I don't know about you, I've never even given myself a shot. I've got a little bit of training with a lemon, to do this to a person. Use their shoulder, use their butt, or their thigh, and just jab it in and push it. You can't hurt the person. If they don't need this drug, it won't affect them. And those parts of the body, really unlikely to hit a vein. I suppose I'm sure I would do it, but there is another easier way. It's a nasal device, and anybody can just put it up to a person's nose, get the plunger, and it sprays the nose. That thing costs over $1,000. So they aren't giving those away. So that's part of the problem, I think, is just the cost of this stuff. This organization that gave me this 2-hour training, so it's not like it was an intensive thing. Their last pitch was for contributions, donations to help fund.
Any questions?
Thanks for your presentation, Greg. And as briefly as you can, we as a county, what could we do in the future to, make sure that this program is as successful as it can be?
Outpatient?
Yeah. A facility, program. What is the greatest need?
What's the greatest need? Ask the legislature to extend coverage for peer support up here.
Okay.
Without that, it's a big part of this program. We can't do it.
Follow-up question, maybe it's leading, but how often do we have people that need detox?
I don't know. If I hear about them, I hear about them. If I don't, I don't. I can tell you whenever somebody needs it, it's a big deal. Because we know if they'll refuse to go, the police will take them. If they want to go, then somebody else has to take them. So just getting them there is hard. One of the clients in treatment this year had been drinking and decided he wanted to get sober. So he went to his doctor and said, I got to stop drinking, and the doctor helped him with it. Started drinking again, went back to the doctor helped him again. Went back a third time, and the doctor said, each time I help you, I tell you, you need to go to detox, and you don't go. This time I'm not going to help you. And I was called, and by this time this person actually had a sponsor, so he really did want to get sober, but he just couldn't stop drinking. The two of us went to the ER. The guy was just ready to quit drinking, but he wasn't going to follow the doctor's advice. And so he did not go to detox. He's sober now, but distance is the big, it's just such a barrier up here. I don't know how to improve that, except other than get to people earlier.
Thanks.
Other
Sorry I
comments
don't
or
have
questions?
answers to these questions, but I just don't.
Any other comments or questions?
So, Greg, you're speaking to alcohol and drug use. Is it all sort of the same treatment, all kind of the same, whether it's opioids or alcohol or meth? I think your structure is the same.
Mm-hmm.
It's a pretty specific structure. Do you see that there are deviations from that might be more helpful in treating specific drugs or?
All of mood-altering substances affect the same part of the brain.
Yep.
So in the disease illness model, you identify the organ that's affected, and you make the repair. And so that part is the same for every drug. first thing a person has to do is abstain. Got to stop using, so the brain can get the message that it has to go back to normal.
So would there be different things to help stopping?
Yeah, but for the clients especially see a difference, and we see a difference also in helping a client make changes. You know, for alcohol, it's a lot of simple things. If you're an alcoholic, don't drive by the liquor store. You know, quit your job at Grandma Ray's. It's about removing
Yeah, don't make it
yourself in the
harder.
early part of recovery. It's about removing yourself from the triggers. Clients can make a long list of triggers, but the thing that they all, no matter what drug they're using, no matter how long their list of triggers, the thing that's common is that it's not, they don't drink because they drive by the liquor store. They drink because of their thoughts when they drive by the liquor store. And it's those thoughts that create the craving. And the craving is an emotional thing. So once you're starting to crave your drug of choice, you're going to make an emotional decision. So what we try to train people to do in the beginning is just avoid those triggers. And then at the same time, we want them to learn to think differently when they're exposed to triggers. You know, what are you thinking? When a person has a slip, now slip is, I've been sober for 3 months, I went to a wedding, I drank a week, but that was the only day I drank. So call that a slip. A relapse is if I just kept drinking. So if a client's in treatment, we tell people, we won't kick you out for using if you're honest about your use. Because we know that's a vivid example of your vulnerability. So what were you exposed to, and what were your thoughts? And when did your thoughts, inspire this craving? When now you're going to make emotional decision, you're going to seek it out, and you're going to use. So, that can be different for every drug. One thing we know about people with who are stimulant abusers is one of the best things they can do is exercise every day. If you can get a stimulant user to start exercising,
there's a
going
difference.
out and walking, their chance of success improves. Because the nature of the drug is it just hits the dopamine system so hard that the brain cannot keep up with the demand. And so they're always depleted. They frequently experience anhedonia, which is, they will say, just the inability to be happy or experience any kind of pleasure. Often their use is just to kick that dopamine system, like stepping on an empty ketchup bottle to get every last drop out. And their recovery time is longer, typically. And it really helps if they can start exercising and getting the naturally good feeling endorphins going every day while their brain recovers and while they're going through this anhedonia. So that's different. So, there are differences in the way you help clients depending on their drug of choice, but everything is directed towards the brain coming back to normal. And the more information they have about their drug of choice, the better. And recovery. And so we show them, it's so wonderful now, you can actually show photographs of a brain and the different electrical activity in the brain when a person is exposed to triggers, the difference between the brain of a sober person and an addict. Being able to give them, they may not understand the photos, I don't know if I do either, but the differences are obvious, and so they really understand they've affected their brain. This is a brain disease that manifests itself in a change in behavior. That's the interesting thing,
Wow.
So teach people to watch your behavior, but your behavior depends on your thoughts. So getting people to understand that you are your thoughts is a big step, because we think, when I'm driving down the street and somebody gives me the finger and I get angry, in the old days I would say, well, that person really made me angry.
Yeah.
But it wasn't that person. It was what I was thinking and believing about what happened. That's a really interesting and intriguing way of thinking about ourselves, but it's new for most people in treatment. And so it takes a long time for them to understand that they really have a lot of power if they can just control their thoughts, if they know when to do that. And the way we try to teach them to do that is, what was I thinking at the time that person made that gesture to me? And am I right?
That's a good
You
one.
know?
Yeah.
Am I right? Or was I
Is that true? Yeah.
Yeah, is it even true?
Yeah.
People have we deal with a lot with anxiety in treatment. It's just amazing how often that comes up as a trigger for treatment.
Yeah.
And it really helps think, at least it helped me, is to ask the question, all these things, awful things you're worrying about that might happen, do any of them ever happen? We're wired to imagine the worst. You know?
And we're also wired to think if we don't worry, it will happen.
Yeah. Or really
So we're actually
superstitious.
preventing it by worrying.
Yeah, well, it feels natural.
Yeah.
I gotta worry about this. I gotta plan for this because the worst thing is gonna happen,
Yeah.
but it often doesn't. So if we can encourage people to just examine how they're thinking in that moment. It's hard though, because right away we're talking about this, what's the problem? Do you want to think about it? We try to meditate at the beginning of every session for 10 minutes or so. Nobody wants to do it. I don't want to do it.
It's anti-art culture.
I don't know why, but boy, do we like doing it. But at 6 o'clock, we don't want to do it. At 20 after 6, we're glad we did it. So, it really is important to teach people not to wait until they want to do something. To start doing it now, you'll want to do it later. And that's AA. AA was brilliant.
We'll take one more question or comment.
So the last futures that I was at in September through the Association of Minnesota Counties, we had Dr. Mark Thomas from the University of Minnesota Neuroscience, who is dissecting the brains of addicts for that nervous system, and they are experimenting on mice how to, instead of getting people to change their behavior, because we don't want to, to actually find that trigger point and figure out if there is a way to activate that. So you've got an addict, we don't want to do lobotomies, we know that didn't work, but they're trying to figure out how do you get to that sensor in the brain to change it so that it's easier.
I think, especially with this reform, boy, we've got this nailed. We really understand addiction.
That was our whole session, and we had doctors and all sorts of stuff talking about the work they've already done and how close they're getting, and how do we do it? How do we come at it differently?
I try to imagine what it's going to be like 50 years from now when we look back, and when I look at 50, I won't be here 50. 20 years from now, maybe 50. 20 years from now, and think, boy, we just didn't understand addiction at all. We just keep learning more and more. I think it's exciting.
Thank you.
Thank you, Greg.
Thank you, Greg.
Really appreciate this. I think you're the right person. You've walked in their shoes. And we'll see what we can do to support you with legislation. We are going, as countywide, we're going to have a countywide legislative meeting in December. And so let's see what we can do to support you, and you can keep us posted with maybe updates too on that in the future. Thanks so much, Greg.
Thanks a lot. Appreciate it.
And director's report now with Allison.
Yes, thank you. I just want to echo the thanks and recognition of Greg and everything that he does for the people of Cook County. We're so fortunate to have him here.
He walks out, exits. Doesn't want to hear any praise.
We've talked about you.
Yeah.
Just saying
thank
nice
you.
things about you.
Allison was.
And then a couple of comments too to respond to the questions about how this might impact staffing. As Greg said, it's still so new. We're still coming on board with the proposed changes. Changes are still being rolled out. But as Greg said, our volume is small enough such that we can be planful and see how, is there enough demand where we can bill for these services and increase staffing within the department, or can this be incorporated into another position that's existing? As you said, a case aide could be trained to do this. We do have several case aides in the department, but again, we want to make sure that it fits within their job responsibilities. So we'll be looking at that as this rolls out. A few other staffing updates. As you know, Allison was here this morning. Allison Plummer was promoted to the Financial Assistant Supervisor position at the last regular board meeting on the 14th. So training is underway with her as I can hand off things from my previous position to her. Her position is posted internally currently through November 29th. Again, assuming that we're able to fill that internally, that will be a big savings for us in terms of training and time, in that presumably that person's coming from within the department, already has exposure to the programs, and potentially access to the systems too. But that's open to all county staff through the 29th. Again, assuming that is filled internally, we would have one final vacancy to fill whoever moves into that position. We are about halfway through our community health survey. We have a meeting on December 19th with that group of community stakeholders. That includes our Public Health and Human Services Advisory Committee, as well as other community partners and providers. We went live with our community needs survey last week. That was posted, I believe, on the 16th, and it's open through December 15th. And we already have 90 responses as of this morning. So really excited that we're getting a lot of great feedback from the community about that. And again, that's posted on SurveyMonkey. You can access the survey from the county website. WTIP has a link posted to the survey as well. We have paper copies available in the lobby of Public Health and Human Services. We can mail those out upon request as well. And that is all I have for updates from our department.
Okay, thank you. We'll move on to board action on C and D.
And I can give a little background on these action items as well. So item C is approving an extension of the temporary employment contract with Linda Waterhouse. Her current contract of temporary employment is expiring, and we are requesting to extend that out 6 months so that she can continue to provide support for our department, as we have an employee who's out on leave right now, medical leave. So that would be through, is it June 15th, I believe would be the date. And that just gives us some room to plan for that. And then item D would be approving the reclassification of our fiscal supervisor position. And I apologize that I don't have those reading in here, but this was recommended by the Personnel Committee to reclassify her position from a C4-3 to a C5-2, and that would be effective today as the date of board approval.
Motion to approve C and D.
Support.
All in favor?
Aye.
Okay, we approve that. We'll move on to committee reports, starting with Arrowhead Economic Opportunity Agency.
Okay, we had our annual meeting in October. It was long. And this agency is very extensive. It amazes me. And I could talk a long time about it, but I guess the challenge that I think we're going to have in the future is most of these are federally funded. And they're going to be related to, you know, of course, Medicare, Medicaid, Meals on Wheels is another thing. Some of those programs are, you know, continuation of them is rather bleak with the current federal situation. So, you know, that could have big impact on people. And I don't know how that's going to relate to the county. I guess that would be, you know, dependent upon how we try to deal with some of these issues that are provided, you know, from a federal agency perspective. And so it's not, a lot of great things are being done, but the future doesn't look all that great. And I know that it's going to affect a lot of programs. Arrowhead buses, Meals on Wheels, and other, you know, in-home kinds of support that come down through this federal agency. So I guess hopefully maybe it'll get better.
Thank you. Arrowhead Health Alliance Joint Powers.
Thank you, Madam Chair. It did not meet.
And back to Commissioner Bersheim on Arrowhead Regional
Okay, well,
Corrections.
I defer to Commissioner DeShaw because I missed the last meeting, and because I sat in on the highway engineer situation. So it's all yours, Bobby.
Oh, yeah. Well, it was actually a pretty short meeting. It was like 30 minutes long.
Well, worth your 5-hour drive.
Yeah. But they just went over the numbers, and there was 104 people under grade no, and they're trying to get the numbers up.
Get the numbers up.
Yeah.
Mm-hmm.
Well, they have room for 144 people there. And
Oh, yeah, you gotta get those numbers up. They have room for everybody.
Costs
It's
a
like the
lot.
clinic and the hospital, they hope for injury.
Yeah.
I mean,
Costs a
that's
lot
how
of
you
money to run the
function.
place, the facilities. So
Yeah.
they're doing some outreach to Wisconsin and whatnot to
Mhm.
maybe get some of their people in there, and they're working on a commercial meat processing plant up there.
Had you been to that facility before, to tour or anything?
Been there to visit.
He's seen the whole facility.
Voluntary.
I wasn't in there.
No, I mean, what was your impression of going there? I've never been there. I'd like to, go sometime.
Yeah, and then Arrowhead Juvenile Center is getting rebuilt, and I believe one of our upcoming meetings is gonna be there,
Oh,
so we can tour that.
oh, okay. All right. I'm all for tours. Okay, anything else? Okay. Community Health Board?
I wasn't able to attend, and I don't think my alternate was either. This is, one of the issues with a lot of committees. This year there's been a ton of conflict. And for some reason, I had something else. I think union negotiations was the issue. But I think the Community Health Board is just doing its thing. There's been some staff changes. And the health assessment, I think, is a big part of what they're doing at this time, that they initiate every 5 years. So we've already heard a report on that, so.
Okay. The Advisory Committee for Public Health and Human Services?
Well, I think Allison covered most of my part, except with one ray of possibly good news. Well, there were other rays, but is Martina, you may remember, is trying to get a grant that would help support disabled young adults and their families to find jobs and have job coaches in the community here, housing, etc. And it's looking more and more like it might come through. So we can all hope, one never knows, right? Yeah, but that would be quite an asset.
Right. And how many would that affect in the community about, do you know?
I only know
Just
people individually, I don't really know
Like
the numbers.
the whole scope?
Right.
Yeah.
But I have seen it work very successfully in large urban areas, and it's wonderful,
Mhm.
because people with disabilities want to be gainfully employed, they want to contribute and
Right.
live as fully as they can.
Mhm. Let's hope that happens.
Yeah,
Mhm. Anything else?
that was it.
I've got the other half of
Uh-huh.
the meeting to say a couple things about. we're always interested to hear the latest from Rita as to this federal community health centers funding. And as of a couple of weeks ago, it hadn't been finally approved, so it's up in the air. I believe she was saying that there was a House approval of some of that funding, but the Senate has yet to act, so they're kind of treading water right now.
Well, the good thing for us is that our clinic's fiscal year starts June, July. So all of these centers that have their year-end start on the 1st or in March, they don't know where they're at because they don't have a set approval yet. So they don't know, do they shut their doors, do they continue, where do they find their funding? So for us, it's kind of a blessing that we have an extra 6 months.
Yeah.
Yeah, she's just at the hospital updating, and so she said, yeah, there is no final answer yet,
Yeah.
but she's hopeful.
Yeah, good. We also talked about putting together a year-end report to this board as to what we're doing on the advisory committee. That's a new thing that is part of our current bylaws. And so we have that in process right now. Sarah has helped us out in a big way by starting this document, and we're working to put some final touches on it, so we will indeed have a report by the end of the year, at the end of the year. We had some discussion about, what do we want to say as far as recommendations for next year. What are the things that need to be worked on? So I won't go into those right now, but it'll be part of a final report that we're preparing. We also had our election of officers for the advisory committee for next year, and so we did a little...
A surprise.
Carla is going to be the chairperson for next year, and I'll be the vice chair, so you'll get to see our shining faces another year. I don't know if that needs to come before this board as maybe next month or something.
Okay, we can get that on the agenda as an action item
Yeah.
along with a report about the year-end activities.
Right, great. And I think that is it.
Okay, thank you. Healthcare Planning Committee. We did meet. We were a small group. Kay Grenlin gave a report about the series in the paper on dementia. She came down to Birch Grove, and I attended that. I attended it just for the fact of understanding folks who are dealing with that, both in-home and in the community. It was a very worthwhile hour that she presented this program, and the outreach in the community, I think, will be greater as people understand that this is affecting a lot of folks in our area, whether it be county or family who live away, and just it was good to just understand the signs and then how you deal with all of that, with friends maybe who are going through it, and I guess probably the top thing that we discussed was the patience that we need to have when we are encountering this type of situation in the family and friends, and that was about it. So North Shore Collaborative.
Thank you, Madam Chair. They did meet, and both Commissioner Dukirk and I were in union negotiations that day, so wasn't able to go to that meeting.
Okay.
Which
Jeez,
is the
you think
story
all
of a
we
lot
do
of-
is union negotiations.
Yeah, well, it's that time of, yeah, we do it a lot. Yeah.
Then moving on to emergency preparedness. Either one of you able to go there?
I don't think we met. We didn't meet. Yeah.
They didn't meet. Okay, that's good.
Yeah.
At least I hope not, because Jan and I didn't make it.
Yeah,
They did meet
yeah.
that one.
You're probably in union negotiations.
Probably.
But they're planning a really amazing meeting for
next month, that I can't go to.
Oh, okay.
I can't remember
Well-
which meeting I'm going to instead, but it's another meeting that,
So maybe, just reach out if either one of you can do something and see if one of us could.
we will be reaching out in January with committees.
We'll
that we
really,
cannot
we'll
do.
really reach out then.
Yes.
Emergency
Yeah.
preparedness is chair
Yeah.
and vice chair.
Yeah.
So be prepared, folks. Next year, you guys get to do it.
What's that?
Emergency preparedness.
Okay, very good. Well, anything else?
That isn't enough hint.
Anybody has to bring up? Otherwise, we will adjourn. Thank you all.